Okay, so we're going to present a 28-year-old male who was stabbed in the chest at a railway station, chest and abdomen. So the call, it was about 10:30 on a Wednesday evening. New South Wales Ambulance was responded to Kingswood Railway Station to attend a 28-year-old male who had been stabbed several times. Police made the call, they were on scene, and that was all the information that we had. The offender was not on scene, the weapon wasn't on scene for us to have a look at. I was part of the initial response in an intensive care car. We were about 3 minutes from the scene. We were on our way to another job and we were diverted. So we were 3 minutes travel time to scene. There was a Dom who was responded from the Penrith Superstation with about approximately a 5-minute time. And there were a couple of cars in bed block at Nepean, and one of the cars managed to clear, and they were with us within 7 minutes of the initial call. So on arrival, it was dark at night, and it was quite cold as well. The patient were on the scene. The police were on the scene, and they'd secured the scene. They didn't know where the offender was, and they didn't know where the knife was. The patient had told them that he'd been stabbed twice by a knife by an unknown offender who then ran off. The area was really poorly lit. It was cold. As we arrived, the police just put on a chest seal dressing, which they had, which we don't carry. We could have asked SOT to turn up if for a chest seal dressing, but yeah, we don't carry them as standard. And you can, for those who are not quite aware of the chest seal dressings, there's a picture of one there, and there's a video here. It's one of the manufacturer's videos of how they go on and how they actually work. But essentially, it works like the old two-way valve. Sorry. The offender and the weapon was not on scene, and police had confirmed that the patient was stabbed once in the chest and once in the lower abdomen, which we were able to see reasonably quickly. So going through our primary survey for massive hemorrhage, the chest seal dressing effectively stopped any hemorrhage from the chest, and there was direct pressure being held onto the abdominal wound, which managed that. Patient's airway was patent. He was talking to us. Decreased breath sounds on the right hand side, which you'd probably expect, and an increased respiratory rate. He had bilateral pulses. He was tachycardic at a rate of 120. There was no concerns of head injury or hypothermia, although it was cold, and we did cut him out of his clothes before we got him onto the stretcher. Everything else really for this, we were probably more interested in drug or alcohol use, but he denied both, and there was no real evidence of either as well. So the initial action, as I sort of said, the scene was very dark and it was cold. So after our quick primary survey, we just basically got the ambulance stretcher, and there was half a dozen police around plus us. So instead of using boards or anything like that, we all just got a bit and lifted him up out of his clothes, which we'd cut, and put him straight onto the ambulance stretcher. So we were inside the back of the ambulance where it was light and warm within 2 minutes of arriving at scene. What this allowed us to do was to have a really good look over him to make sure that there was only 2 stab wounds and they were the only wounds that there was, which there was. It gave me an opportunity to have a good look at his abdominal injury, which was just oozing blood. There was no real significant hemorrhage, but we could see the wound size was similar to the size of the wound in the chest. And because we had no idea of the weapon was on scene, we had no real idea of how deep that could have gone. But in the right side of the abdomen we're sort of worried, and it was sort of right lower, but yeah, we were sort of worried about whether perforated bowel, liver, stomach, etc. So we cleaned him as much as we could, attached some telemetry, got a basic set of obs. By this time, the Dom had arrived on scene. They took a quick handover, passed off a missed report. As we gave them the odds, passed off the missed report. Retrieval couldn't get to us, so it was basically decided that as soon as we had a backup crew, we would get a driver to jump in the car for us, and we would toddle ourselves off as quick as we could to Westmead. In this time, we managed to throw an 18 gauge while we were nice and still. And there's the initial obs. So GCS was 15, increased rest rate and decreased breath sounds on the right hand side. But interestingly, the saturations and the capnography was not really that compromised, or was his blood pressure. He was a sinus tachycardia at a rate of 120, but in all, he seemed to be in not a bad sort of spot. We repeated obs regularly. So T1, trauma patient. So we bypassed to the major trauma hospital. So bypassing Nepean, we went to Westmead. As we were travelling, we sent a pre-notification message to Westmead gave them about 15 minutes notice so they could be prepared for us as we walked in the door. As we were driving, we managed to pop a 16 gauge cannula in the left cubital fossa. We administered a total of 7.5 milligrams of morphine and 20 of ketamine for analgesia, which worked really, really well. And the rest of the stuff we did was preemptive in case. So we were trying to visualize what deterioration would look like in this patient and manage that and be ready for that should it happen. So we drew up IV CSL Hartmann's. It wasn't started. It was attached to the left cannula. It wasn't started, but it was there in case we needed it. And if the patient had lost any radial pulses, we would give 250 ml boluses until the radial pulse came back. We were not concerned and didn't think that this patient had a head injury at all. We marked him up for a needle decompression. We marked up the right side, which is the mid-clavicular line in the second intercostal space, just above the third rib, and confirmed this with the angle of Louis. And I'm going to talk a little bit further soon about when we would have decompressed, but he wasn't hitting any indications for us to decompress. The patient was discreetly, so he wasn't aware, we'd size him up for an OPA, an IG-gel and a tube in case of respiratory arrest, deterioration of respiratory arrest. The preference would have been to get to an ETT, because it was a respiratory cause that caused deterioration, we would have preferred to get a definitive airway in him. We had capnography attached to him, but no oxygen at this stage. So had he started dropping oxygen saturations and deteriorating, that would have been the first call, was to add oxygen to the nasal prongs of the capnography, and then to change into a mask, and then have him pre-oxygenated if we had to actually intubate him. Observations by this time, and he'd had some analgesia. He was inside the ambulance, he was warming up. So GCS 15, his respiratory rate dropped back down to 20. He still had decreased breath sounds on the right hand side, but his saturations were 96, sort of unchanged, or as was his capnography. His blood pressure had improved slightly. His heart rate had come down a bit. So, and the patient had now said that his pain was now a 2 out of 10. So essentially his hemodynamics were quite stable, and he was compensating really well for his potential injuries. But it was important for us to be aware of what his injuries could have been and what deterioration would have looked like. So talking about needle decompression. So we had marked him up for needle decompression, as I said previously, in the mid-clavicular line, second intercostal space, just above the third rib. But we had not decompressed him because he was hemodynamically stable. However, our threshold to decompress him would have been any of the following. If his level of consciousness dropped, if his respiratory rate increased or decreased to above 30 or below 10, a drop in blood pressure below 90, or an increase of heart rate above 120, thereby compensating or poorly compensating hemodynamics, and physical signs of increased work of breathing, subcutaneous emphysema, or a tracheal shift. There's a clip here, which feel free to go and have a look at. It's a YouTube clip which will talk to you about needle thoracostomy and where correct sighting is and all that sort of stuff as well. We arrived at the emergency department with the patient had remained quite stable with us, which was good. There was no further treatment required by us, and when we got to the hospital, there was no further treatment required to them until they were getting him ready for emergency surgery. So while the patient did remain stable, the potential for deterioration was significant, and that's how we attacked the job, being ready for having a good idea of what deterioration looked like, and being ready if that started happening. So medical retrieval were unavailable for this job, but had they turned up, they could have value added by being able, had the patient deteriorated, to have blood products ready and TXA or tranexamic acid. So I'm just going to have a bit of a chat about TXA. So essentially what TXA does, it inhibits plasmin formation and displaces the plasminogen off the fibrin surface, which stops the processes of fibrinolysis. So to simply explain that, it stops the body's natural reaction of formed blood clots breaking down, thereby reducing hemorrhage. It's also beneficial in places where you can't place direct pressure, like in the abdomen. So you can't use direct pressure to actually occlude the hemorrhage. There was a couple of trials done, one in 2010, the CRASH 2 trial, and the MATTERS trial in 2011, both looking at trauma patients with significant hemorrhage. And both of those trials concluded that compromised patients benefited from the administration of TXA. Queensland Ambulance Service use TXA, and what they have, for when it's indicated, or to determine when it's indicated, they use the coagulopathy of severe trauma, or a COSE score, to assist clinicians when they can use TXA. And you can see it's on the side of this is a five-stage consideration, whether they're trapped, if they have a decreased systolic blood pressure, their overall temperature, major chest injury likely to require interventions, or likely intra-abdominal or pelvic injury. Our patient, as he presented, would not have met the requirements for TXA, or would not have met these requirements for TXA. But just remembering, we were trying to be proactive and not reactive. In being proactive, patient might not have been administered TXA, but it certainly would have been drawn up and the threshold for giving it established, so that if the patient did deteriorate, we would have been administered TXA as soon as it was indicated. All right, there's some references, and I thank you very much for taking the time to watch this presentation.